Hello and welcome to the Grand Rounds for Minnesota Regional Spinal Cord Injury Model Systems, or we call it MINSCIMS for short. Thank you all for joining us today. So MINSCIMS is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, or NIDILRR, the Spinal Cord Injury Model Systems program. And the purpose of the SCIMS program is to support innovative projects and research in the delivery, demonstration, and evaluation of medical, rehabilitation, vocational, and other services to meet the needs of individuals with spinal cord injury. Next slide, please. MINSCIMS represents an exciting new partnership among the following institutions: Courage Kinney Rehab Institute in Minneapolis, Mayo Clinic in Rochester, Regions Hospital in St. Paul, and University of Minnesota in Minneapolis. Next slide, please. Our community collaborators include Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, and Get Up, Stand Up to Cure Paralysis, the Paralyzed Veterans of America, United Spinal Association, and the North American Spinal Cord Injury Consortium. This system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency medical services, acute care services, acute rehab services, and post-acute services. My name is Dr. Angela Hanks-Philippus, and I'll be the moderator for today's session. I'm a research professional at the Department of Rehab Medicine at the University of Minnesota Medical School, and I'm a co-investigator with the MINSCIMS. Next slide, please. A couple of housekeeping things. So the University of Minnesota has organized the CME for today's webinar. Please see the chat for information on how to record your attendance and claim CME credit for attending this webinar within 24 hours of this event. This meeting is being recorded and will be posted on the MINSCIMS website. To earn CME credit for today's presentation, please click on the link in the chat. And due to the number of registrants for today's webinar, we've placed phone lines on mute to reduce audio feedback. However, we welcome and encourage audience participation using the Q&A function. If you have any technical or logistical questions, we ask that you please submit those in the chat to Dan Kelly. And we extend a huge thanks to those who work behind the scenes to make these webinars possible. Next slide, please. The title of today's presentation is Restoring Upper Extremity Function After Spinal Cord Injury. And the speaker for today's webinar is Dr. Kitty Wu. Dr. Kitty Wu is a hand and reconstruction surgeon at the Mayo Clinic. Her diverse training and background in the fields of plastic, orthopedic, and neurosurgery allows her to provide comprehensive care to patients with complex clinical problems from a unique perspective. Her specific interests include upper extremity reconstruction in adult and pediatric patients with cervical spinal cord injuries, surgical spasticity management following spinal cord injury and brain injuries, and traumatic injuries requiring soft tissue, bone, tendon, and nerve reconstruction. Welcome, and thank you so much for presenting. Next slide. I'll hand it over to you now, Dr. Wu.
Great. Well, thank you very much, Angela, for the opportunity to be here, to be a part of this Grand Rounds. And I also wanted to say thank you to Jeff and Nikki Tauzin for taking the time to join us today as well. Jeff is a patient of mine who's now had surgery on both sides, the second side just over 2 months ago, actually. So I'm hoping to spend the first 30 minutes to go through a general overview of upper extremity reconstructive surgery and tetraplegia, and then also to save enough time for Jeff to tell you his story and then also his experience in terms of having surgery as well. So as this audience knows very well, upper extremity function is important and prioritized in patients with tetraplegia. This is now some older study data, but this is asking patients who've had a history of spinal cord injury, what gain of function would dramatically improve your quality of life? And out of all of the factors listed, almost 50% of patients would prioritize their upper extremity function beyond everything else listed here. And this was also the case for patients more than 3 years after their injury. So although patients are incredibly resilient and find different ways to do things, this function was as important to them 3 years after injury as it was right after injury. And in a different study from UK and including Dutch patients, 75 to 80% of patients also reported that hand function would markedly improve their quality of life. The higher bars here are patients who are tetraplegic, and the lower bars are patients who are paraplegic who do have hand function. And then looking at some more recent data from a 2021 European multi-center study. The letters here are small, I apologize, but down the side are patients who have a C5 level injury at 6 months, at 1 year, a C6 injury at 6 months and 1 year, and so on and so forth. And this was looking at the percent of patients who would require full assist, partial assist or adaptive devices, or are independent for feeding. And this shows that, for example, if we look at a patient who is a C5 level of injury at 1 year, 34% of patients still require full assist for feeding. We look at a patient who's a C6 level at 1 year, only 4% of patients do. So even seemingly very small gains, that one additional level of function is actually incredibly meaningful for patients in terms of their independence. And with surgery, that's what we're able to do. We're able to give maybe 1 or 2 additional levels of function, but this can be incredibly useful. So what can surgery offer? One of our first priorities is restoring elbow extension, so triceps function, and if a patient doesn't have that ability already. This provides patients the ability to push off and to help with some transferring. They can then use their triceps to use a manual wheelchair, especially going up ramps are difficult if you don't have any triceps function. And most importantly, this increases their interactive space. They're able to reach out into the world, to take something off a shelf, to reach out and shake someone's hand, for example. So we can help with triceps. The next is hand function, and we divide that into grasp and pinch. So grasp is the ability to bring these 4 fingers together to almost form a fist, and pinch is the ability to hold something or pinch between your thumb and your index finger. So if a patient is able to regain grasp or pinch, then they're able to, for example, self-catheterize. They're able to eat and drink with more independence. They're able to hold a pen to write without adaptive devices. So this is really crucial to patients, and this is where surgery can be helpful. When we look at the literature, though, there are some barriers to patients receiving upper extremity care or surgery. So this is data from 2016, but in the US, there's an estimated 300,000 patients who've had spinal cord injuries. And of that, 60% of patients have injuries at the cervical level, so tetraplegia. However, only less than 10% of patients who would be appropriate candidates for surgery actually undergo upper extremity surgery. So the next question after that is, what are those barriers, and what is maybe preventing some patients from accessing care? This was our survey to patients who've had tetraplegia and spinal cord injury. And when patients first learned about surgery from a surgeon, they had a negative impression 67% of the time. Whereas if they first learned about surgery from a non-physician, they only had a negative impression of surgery 19% of the time. Patients also believed that the potential benefits of surgery were worthwhile if they were told by a surgeon only 60% of the time, but 100% of the time if they heard about the potential benefits of surgery from a non-physician. And similarly, patients believed that the gains were worth the risk of surgery only 20% of the time if they learned about surgery from a surgeon, but 82% of the time when they learned about surgery from a non-physician. So overall from this study, if a patient learned about surgery from a surgeon, they were almost 16 times less likely to want to undergo surgery. So this might mean that surgeons are just maybe poor communicators, but I think it really speaks to the level of trust that patients have to everyone else in this call, everyone else involved in their care, their physical medicine, rehab team, occupational physical therapists, nursing staff, friends and family, who've been there for them from day one, rather than myself or a surgeon that they're meeting for the first time and I'm talking about surgery and immobilization and recovery and all the therapy afterwards. It's a lot and it can be very overwhelming. So patients are overall much more accepting of the idea of surgery if it's broached by someone else. So for me, from the surgical side of things, I truly appreciate and I recognize it's a real privilege for me to be involved in the care of your patients. And hopefully through this presentation, I'll be able to convey some of the positive aspects of what surgery may be able to offer. So then who is a candidate for surgery? Patients have to be at a neurological functional plateau. So meaning I do not expect any further intrinsic recovery over time. And I tell my patients, Mother Nature is better at her job than I am at my job. So anything that they're able to get back on their own will be much better, much more functional, easier to use, more intuitive to use than anything that I could restore surgically. Based on our hand surgery literature, for patients who have a complete spinal cord injury, if they don't have anti-gravity or what we call M3 function of a certain muscle at 6 months, then I don't expect that they will recover anti-gravity functional use of that muscle on their own. So 6 months in a patient with a complete spinal cord injury is typically around the time when we can start to make some of those decisions for surgery. I do like to usually meet patients a little bit earlier so I can talk about what surgery may look like, but we don't really make any decisions before that. This doesn't really apply to patients with an incomplete injury. I think there's a lot more potential for natural recovery, so we tend to wait a little bit longer before surgery in that group. Patients have to be medically stable, so no open wounds. We're not dealing with infection, pressure wounds, infection, or bladder infections. I want them to be as optimized as they can, as best as we can, to get them through the surgery safely. And finally, there's motivation. So there's a lot of therapy that comes in after surgery. So patients have to be able to have the time and the ability to get to therapy as well. We'll touch on this a little bit later in the presentation, but patients have to have available donor muscles. There have to be muscles or nerves that are strong enough for me to potentially transfer to give them that function. For most patients, this is optimally at kind of a C5 level. If patients have higher levels of spinal cord injury, that sometimes makes it a bit more challenging. I do have a few patients who have a C4 level of injury that there's some things we can do, but I think the C5 is sort of a good level to talk more about having more predictable results after surgery. And the more important one also is that patients have full passive range of motion of their joints. So I have to be able to move their hands very easily to make a fist. And if I'm not sure if there's any therapists that are on the call or on the line here, if patients are potential candidates for surgery, I do like to work on full passive range of motion and to prioritize that. I know some centers do like to have patients stiffen up a little bit so that when they use their tenodesis, they're able to use their fingers to help open things or to kind of use it as a hook grasp. But for patients who are potential candidates for surgery, I want to avoid that. If they have any joint contractures, it actually makes it much more difficult and challenging for surgery. Okay, so thinking about spinal cord injury as a hand surgeon, this is very oversimplified. So I apologize to those in the group if this is sort of how I break it down and think about things. So above the level of injury, there's normal function of those muscles. Those muscles patients are able to control. But below the level of injury, there's paralysis. So with surgery, the goal is to transfer muscles or nerves that are above the level of injury, that are healthy, that patients can control, and to move them to help restore function to muscles that they've lost, so below the level of injury. And we can do that either by transferring muscles or by transferring nerves. In terms of our reconstructive priorities, so first is elbow extension. That helps to bring the hand out into space to interact with the world. Following that is wrist extension, and everything in terms of reconstruction builds upon a patient's tenodesis. So if a patient does have wrist extension, then naturally their fingers fall into a pattern as if to make a grasp or to make a fist, and their thumb sort of naturally falls into this pinch position. If they do have tenodesis, then I can build upon that, and we can try to give them active pinch or active grasp. And if they have that, then we can work on trying to open the hand a little bit more. So I mentioned we can do this either through tendon or through nerve transfers. And again, this is transferring something from above the level of injury to restore function below the level of injury. So I tell patients that tendon transfers is similar to if you were in a buggy or in a horse race and one of your horses was injured, you can bring in a new horse or a new motor to try to power that muscle or to pull that cart. So I'm physically rerouting a healthy muscle and I'm suturing it to another muscle to now give it new power, to generate power. Nerve transfers, on the other hand, is almost like rewiring the electricity in your house. So if an appliance doesn't work, then I'm adding in an extension cord from above the level of injury to try to now power a new muscle or new function from below the level of injury. And the way I explain this to patients, it's like borrowing from Peter to pay Paul. So I can't give new function without taking something away. But our upper extremities and bodies are beautiful in that there's a lot of redundancy. There's a lot of muscles that do the same thing. So for example, there's 3 muscles that help you bend your elbow, the biceps, brachialis, and brachoradialis. I can then take one of those muscles, typically the brachoradialis, and I can transfer that to do something else. For example, moving the thumb or moving the fingers. In doing that, I'm not taking away their elbow flexion ability because they have 2 other really strong muscles that are doing that, but I'm able to borrow their brachoradialis without them feeling any donor morbidity and now provide them with new function by transferring. So usually we tend to combine these techniques together, and we'll talk about some of the differences and why patients and myself might choose one strategy over the other. So for tendon transfers, patients are splinted after surgery and they're immobilized. This is for at least 2 weeks. After that 2-week period, they're in a splint that's removable, but they're doing therapy. And this is intensive for that first 2 to 3 months after surgery. So they're seeing a therapist, ideally 2 to 3 times per week, but at minimum once a week. And they're doing therapy themselves at home, and that's 3 to 4 times a day, their dedicated therapy at home. We see the results of tendon transfers at about 6 to 8 weeks after surgery. So after that intensive therapy period, patients should be able to then start using that new function. Tendon transfers compared to nerve transfers tend to be a little bit stronger. And tendon transfers are always an option. What I mean by that is if I see a patient 10, 15, 20, 30 years out from their injury, if they have strong muscles above the level of injury that I can transfer, then we can always potentially do tendon transfers. So there's no time sensitivity to that. Nerve transfers in comparison, patients just have a soft dressing after surgery, so they don't need to be in a splint. They're not immobilized. It's a soft dressing. They're able to move that joint. And there's no real therapy until that nerve transfer starts to reinnervate. So unlike rewiring the electricity in your house, the nerve transfer has to reinnervate. That nerve needs to regrow down that new pathway to the muscle. And nerves grow very slowly at 1 millimeter a day or 1 inch a month. So it can take time. The earliest would be 6 months, but more often between 1 year and 1.5 years before we start to notice that new function. And we don't start therapy until we do. So with that said, we don't notice the results of surgery until about 6 to 18 months after surgery, depending on the type of nerve transfer that we're doing. Contrast that to the tendon transfer, which we see the results of pretty early, but patients are doing very intensive therapy during that first post-op period. The nerve transfers tend to be more dexterous. So if I'm doing a nerve transfer to help restore finger function versus a tendon transfer for finger function, the nerve transfers tend to be a little bit more fine, give you a bit more fine motor control, but the tendon transfers are stronger. And nerve transfers may not always be an option after 1 year, and I'll talk a bit more specifics about that. So nerve transfers, depending on the level of injury and type of injury, after 1 year may not be something that we can do. So to focus on just the tendon transfers for a few slides, this is the International Classification for Surgery of the Hand in Tetraplegia. It's a mouthful, so we shorten it to the IC group or IC classification. And this is what I use as a hand surgeon, as a template in terms of deciding my reconstructive plan. So if a patient is a grade 1 or an IC1, what that means is that they only have one muscle below the elbow that I could potentially use as a tendon transfer donor. So this particular patient would just have brachoradialis, which means they do not have any wrist movement, they do not have any finger movement. So they essentially have a wrist drop. If I see a patient who is an IC1, they don't have tenodesis because they're not able to move their wrist. So with the tendon transfer, my goal is to give them back wrist extension. So I would transfer that brachoradialis tendon to the ECRB to give them wrist extension ability. And with that wrist extension, then they will start to get some of that tenodesis, and we can do other procedures later on to fine-tune their tenodesis to try to give them a bit stronger grasp and pinch. But that's not grasp and pinch that they're able to control. That's all driven by their wrist and then them using the tenodesis effect. If we would look at a patient who is an IC2, this patient, it's additive in terms of a level, now has brachyradialis that I can use. They also have ECRL, which is one of your wrist extensors. So for this particular patient, they already have wrist extension. They're able to do that, which means that I no longer need to use the brachyradialis muscle to give them back wrist extension. And instead, what I can do is move down my reconstructive ladder, and I can transfer the brachyradialis to the FPL, which moves the thumb, and give them active pinch ability. And if we move one further down, a patient who's an IC3 has brachyradialis, and now they have two wrist extensors. They have ECRL and ECRB. So they have wrist extension, but I can borrow one of the wrist extensor tendons to do something else as well. So now I can bring BR to FPL for pinch like we did earlier, and I can also now borrow ECRL to the FTPs for active finger flexion for grasp. So all of this is predicated on the patient's level of injury, how many muscles are strong enough above the level of injury that I can use without downgrading or taking away really useful function. And then I move down my algorithm. So first is wrist extension to give them back tenodesis, and then it's that active grasp and active pinch to give them back some of that hand function as well. Okay, so moving on now to the nerve transfers, just for one slide. I mentioned earlier that nerve transfers are not always possible if it's outside of a year. So again, this is a very simplified view of neuroanatomy, so I apologize to the other providers in the room. When I examine a patient, the way that I describe or think about the level of injury is I split it up into what I think are upper motor neuron versus lower motor neuron. If we look at lower motor neuron injuries, we know that from our peripheral nerve or brachial plexus nerve injury patients, if there's an injury to the lower motor neuron, then that muscle will undergo irreversible changes after about 12 to 18 months. So if you can see my cursor here, I simplify this and I say there's an upper motor neuron that starts in the motor cortex with the axon that goes into the spinal cord. The lower motor neuron starts in that anterior horn, and there's an axon that goes into the muscle at the neuromuscular junction. So if there's an injury to this lower motor neuron, where this nerve is no longer talking to the muscle, after that 12 to 18 months, if that muscle does not receive a nerve signal, it gives up. So even if I'm able to get a really strong signal to that muscle, it's already undergone these fibrotic changes, then I'm not able to bring it back. However, spinal cord injuries are a bit different because they are upper motor neuron injuries. So it's an injury to this first part of the pathway here. The cell body and the lower motor neuron is still connected to the muscle, essentially keeping that muscle alive. Patients can't move or control that muscle. That muscle is still paralyzed because it's not connected to the upper motor neuron. It's not connected to the brain, so they're not able to use it, but that muscle is still alive. If I can bring a nerve signal there, I can still potentially re-innervate that muscle. So when we go back to this first slide that we were looking at, above the level of injury, there's normal function. These are healthy nerves and muscles that haven't been injured that patients can control. Well below the level of injury, these are muscles that are upper motor neuron, that have an upper motor neuron injury. So patients can't control this because it's not connected, but those muscles are still alive and they're waiting for reinnervation. If I can get a nerve signal there, then that muscle potentially could start working again. It's that middle section, though, that is challenging. And that middle section is right around the zone of injury. Although we think about spinal cord injuries as C5, C6, C6, C7, or at a specific level, we know that the actual zone of injury to the spinal cord is much larger and much more significant. So within that zone of injury, there's going to be a mix of both upper and lower motor neuron injuries. And in that section, right around the injury, those muscles do undergo that irreversible change. And that if there's no reinnervation within that 12 to 18 months, then I'm not able to get a signal there. So I do have a time crunch to get a nerve signal to the muscle. So that's why I say it's not always possible more than a year after an injury for us to do a nerve transfer. The way that I check though, and I tell patients, I will always check during surgery if you'd like to have a nerve transfer. I'll check to see if that's possible. And if not, then during surgery, I can pivot and I can do something else. And the way that I check is with intraoperative nerve stimulation. I should have mentioned a little bit earlier, if there's any community members, I do apologize for some of the more graphic photos. So there are a few other photos coming up from surgery. So this is a young patient she's 31 and she's a C6 Asia A level injury from a diving into a shallow lake. So here we're doing a supinator to PIN nerve transfer. The PIN innervates the finger and the thumb extensor. So this is to help her be able to open her hand. And the supinator helps you be able to turn your hand palm up. So this is the incision that we use for that particular nerve transfer. And this is a close-up of that nerve transfer. These are the supinator nerve branches here that are these small structures in the white loops, and this is the PIN nerve. And during surgery, I stimulate those nerves directly. So this is stimulating the supinator nerve. The patient's under general anesthetic, so is asleep, but I'm able to stimulate the nerve and produce supination. Supination, though, this is a healthy muscle or nerve that's above the level of injury. So when the patient's awake, she's able to actively supinate her hand palm up and to produce this action. Next, I'm going to be stimulating the PIN nerve. So this is now a nerve that is below the level of injury. So when the patient's awake, she is not able to move her fingers or to open her hand and her thumb like what you're seeing here. But because this is an upper motor neuron injury, the lower motor neuron, which is the nerve that I'm stimulating, is still connected to the muscle, and that muscle is still working and still active. So when I stimulate it during surgery, I'm able to produce that finger extension. So if I'm able to see that, then I'll say this is safe for me to do the nerve transfer because the lower motor neuron is still healthy and still intact. And there's some patients that I've done surgery 10, 15 years after their injury, and if I'm still able to stimulate it, then it's okay for us to do the nerve transfer. But if I stimulate and there's nothing that happens, then we'll do something different and do the tendon transfer. So that's why I'd say for the nerve transfer, it may not always be possible, but I do check during surgery. So this is the nerve transfers. We suture this with really fine sutures, and patients are just in a soft dressing after surgery, so no immobilization, but they have to regrow and regenerate through that nerve pathway into the muscle. So this is her now at 6 months after surgery. She's just starting to re-innervate this nerve transfer. So now she's able to extend her thumb and her fingers. And you'll see me resisting her forearm rotation. So what I'm doing there is I'm trying to have her activate the donor muscle. So the donor was the supinator. I'm trying to have her resist me and focus on supinating her hand and trying to open her fingers. So when we start to see this reinnervation, we start to see those muscles work, that's when we would start the hand therapy. Unlike the unlike the tendon transfers when we start the therapy right away. So now to show what tendon transfer surgery might look like, this is a patient who's 46 and he had an incomplete spinal cord injury. So he was a C6 level, an Asia D level, central cord. So you can see focusing on his left hand, he's using his tenodesis there to bring his fingers down, but he's not able to bring them into his palm and to make a fist. His other hand is actually quite functional. So this injury was more than 25 years ago, and he's been able to do most things. He farms, he does everything using his right hand, and his left hand he kind of uses as a helper. So we talked about the different options of what we could do with surgery. He said, you know, this has been 25 years since his injury. He didn't necessarily want to wait another year or year and a half for a nerve transfer to potentially work. I told him as well, you're far from injury. We could do a potential nerve transfer. I would stimulate the nerve during surgery like I showed you. And if the nerve did not stimulate, then we could do a tendon transfer. But if it did, we could do the nerve transfer. But he said, I'd rather have something that works a little bit faster. He's able to get to therapy. He was able to have the time before the farming season started to do therapy. So he decided to do the tendon transfers. With the tendon transfer procedure, there's multiple different parts to it, and it usually includes 5 or 6 different different procedures that I do all in one surgery, so all together. that often involves me fusing the thumb. Many patients with spinal cord injuries, their thumb is very flat into the palm of their hand, so they can't bring their thumb out to get their hand around a certain object. So I will fuse the basilar thumb joint here to bring their thumb out of the palm a little bit more. I then do an intrinsic tenodesis, that's to help recreate the intrinsic musculature in the hand. And then the two tendon transfers, the BR to FPL, that's the one for pinch ability, and the ECRL to FTPs, that's the one for grasp. So this is that thumb fusion surgery. I use 2 staples. They typically stay in with patients for life. I don't plan to remove them. And that again is to help to bring the thumb out of the plane of the hand so that patients can bring their hand around an object. This is that first tendon transfer. So the hand is here and the forearm is here. I'm bringing the brachioradialis tendon into the FPL tendon. The FPL tendon is what typically bends the tip of the thumb down, and this is below the level of injury, so paralyzed, and patients aren't able to do that. But I'm bringing in a new motor. I'm hitching a new horse to that cart. So I'm bringing in the brachioradialis and suturing that into the side of the FPL tendon for pinchability. This is a different patient, obviously, but we're doing the ECRL to FTP tendon transfer. So this patient has 2 wrist extensors. Both of these, this is the ECRL, this is the ECRB tendon. Both of those tendons bring the wrist up for wrist extension. And because the patient has 2 strong wrist extensors, I can bring one of them, I cut that tendon here, I reroute it around to the palm or the volar side of the wrist, and I suture that into the FDP tendons. And those are the tendons that bring your finger in to be able to make a fist. And that is what is able to give the patient stability for grasp. So this is the patient now. We haven't done anything to his right hand, but looking at his left side, you're able to see that he's got better ability to make a fist. And he's able to bring those fingers better down into the palm. And he also has a stronger pinch and is able to bring the thumb down now onto the side of his index finger. And this is him after very intensive therapy, but 4 months post-operatively. At usually 4 months, patients don't have to wear any type of splint or mobilization. The tendon transfers have healed and are strong enough that patients are able to do most things that they want to. And he was back to farming at this point as well. Okay, so for the last maybe 15, 20 minutes, I did want to give Jeff the opportunity to tell a little bit more about his story and then also his experience with surgery. The first one we did more than a year ago, and the second side more recently. So Jeff initially was seen here and treated at Mayo Clinic after his injury in July, just over 2 years ago now. He had a C5 Asia A spinal cord injury. So Jeff, if you would be able to maybe tell a little bit about what happened in your injury itself.
Yeah, I was injured July 15th, 2 years ago. A dead tree fell on me at an outdoor event. Pretty significant injury. And then I was flown to the Mayo Clinic, and I think probably about 4 weeks after some recovery, I met with Dr. Reed. Dr. Reed told me I was a good candidate for the surgery. And I will say at that time, I was like, I'm not doing any surgery. And I think this is why a lot of patients don't end up doing the surgery, is because we all believe we're going to heal. And then if nobody follows up with us or keeps in contact with us, we probably forget about it and kind of move on with our lives. But Dr. Reed did reach back out to me roughly 6 months later. And I was extremely reluctant to do the surgery because it's kind of like you're giving up. Basically, I'm kind of giving up on natural healing. And it's like, okay, I got to have a surgery. So I am glad I did the surgery because, I did work with my hands pretty consistently. I say probably 3-4 days a week, I would do my own kind of rehab, trying to get my tenodesis stronger. And I did make some progress, but not nowhere near the pinch I have now in my left hand. Before I couldn't pick up a cell phone without like the little knob on the back. Now I can grab my cell phone, pick up my cell phone. I can open the doors of my house. It makes things a lot easier. As far as recovery from the surgery, I think going into the surgery, I knew it was going to be, I guess, moderately invasive. So I was prepared for that. Problem was I was underprepared for how I'd feel kind of going back, losing some mobility. Having, I guess it was really only the first couple of days having to get transferred with the Hoya left, and then getting home, and then having to have my wife assist me with almost everything again was difficult. So it was definitely a kind of two-step back process, and it kind of probably the first 2 weeks I really let it get to me mentally and kind of struggled, and then I kind of slowly kind of got back into it, and started going to therapy, started feeling good about it, and my hand actually started working, and so uh, it you know I can see the light at the end of the tunnel. But I will say the first hand was definitely mentally was a struggle. Second hand was easy. I knew what to expect. I think too with the second hand, my hand wasn't quite as fragile, I guess, the feeling. So uh, my right hand, which is the second hand I did, probably didn't feel as tender. Whereas when we did my left hand felt very tender for a long time. So it took me probably, I want to say roughly 5.5 months to get back in my manual wheelchair, which is a kind of big deal for me because I kind of like to try and stay in my manual chair as much as possible. But I think overall, I'm really glad I did this surgery. I think what hurts a lot of spinal cord injury people is we all believe, and I think it's good to believe that you could get better, but at some point, you have to come to the realization of which your injury is, maybe look at the statistical data and make a decision. That's what I did. And even making that decision, I felt like I was kind of giving up. So,
Yeah. Just to take a quick step back about your surgeries, the first one we did nerve transfers on both sides for your
yeah,
finger opening. And then the second surgery we did your left side first, which was those tendon transfers, which you did need to be immobilized for,
yeah.
and not able to use that hand. I'm just going to show a couple of videos that you and Nikki were able to show me from some of your therapy sessions, and working on pinch and working on your ability to grasp. To your point, I think it's so poignant and very good for me and other providers to hear that having the decision to have surgery is almost like giving up on your own recovery in some way.
Yeah.
And that combined with feeling like you're taking a step back because now you can't use your one hand for things. I think with the tendon transfers we can offer at any time. So if there are patients on the call or community members, I don't think it's ever too late for you to reach out to see a hand surgeon or specialist. Even if you're far from injury, there are potential things that we can suggest or do. Our hand therapists are also amazing to suggest other adaptive things or orthotics that may be able to help with your function. So I don't ever think that it's too late, but it is hard making that decision early on when you're between that 6 month to a year mark of waiting for your own recovery versus surgery. Can you talk a bit about some of the things that you're able to do now with your hands that were challenging for you before?
Grabbing a regular doorknob, opening a door before it could have took me 5 minutes to open a door, or I would have to try and lean over and kind of smash it together with both hands. Now I could just lean over with one hand and grab the doorknob with my left hand, open the doorknob. Uh, I'm right-handed, but right now I'm eating with my left hand just because I just had surgery on my right hand. And so I think it was an advantage doing my offhand first.
Yeah.
That way I knew what to expect going in with my right hand. And I can already tell the recovery is going faster on my right hand. Uh, Definitely just pinching things and picking up things. I mean, it's kind of funny, but I couldn't grab a chip to dip it and dip. So now I can do that with my left hand. And just everything, I really do have, I can put a lot of pressure on things. So my grip's pretty strong. So I can, pick up things with weight to it. I mean, I haven't tried to pick up a dumbbell yet, but I'm pretty sure I could pick up probably at minimum a 10-pound dumbbell. So yeah, definitely much stronger pinch. Yeah.
And I think that's a good point. For surgery, I tell patients that they are able to choose which side they want us to do first. And sometimes we do slightly different things on one side versus the other. But for most patients, because of that immobilization, I don't want to take away their dominant or newly dominant side. We'd rather do the side that they use less or the side that they feel is a little bit weaker, so that that immobilization is a bit easier to tolerate. And then also, as you mentioned too, to kind of go through the process of therapy, know what that's like, so that we get that hand as good as we can before we do the other side. So we start with the more dominant or useful side. It can feel, that step back can feel like 10 steps back before we do 2 steps forward, and it's more challenging that way.
That makes sense.
Is there
Yeah.
anything that you wish you knew about surgery before you went, before you decided to have it done?
No, I think I think you and Dr. Reed prepared me well. I think the first hand for me, the left hand, I just personally underestimated the mental aspect to it. And like I said, just, you know, spinal cord injury is probably one of the worst injuries a human can sustain. And you lose so much function and mobility. And then when you start gaining a little bit back and some independence, to go back and reverse again, it was just overwhelming to me. So I think that was the main thing I took out of it that I probably like to share is, you know, I guess make sure that that is kind of maybe overly communicated, prepare yourself mentally. It can be mentally challenging, which obviously the injury itself is extremely mentally challenging on a day-to-day basis. So I think as far as the nerve transfers, that was a piece of cake. I mean, that wasn't really anything to, and and even, the second, doing my right hand, it's been pretty, my wife and I knew what to expect. I knew what to expect. It's been much easier. So
Yeah, yeah. I think the added piece that was a little bit more challenging in your case is that Jeff and Nikki live in Louisiana. So they had to
yeah,
navigate traveling and flying and coming here for surgery. So we typically met the day before surgery, had a surgical date selected, had them stay in town for about a week so that they could meet with our therapist and have a custom splint made and kind of start the early therapy before they traveled home. But that is a lot of coordination, and even getting on the plane and transferring and all, getting into a car. All of those were sort of challenges that you had to face as well. But certainly things that we can try on my side, we can try as best to accommodate, trying to get everything done within a reasonable amount of time, and get you back home.
yeah. I mean, it's a pretty amazing process to be honest with you. I mean, this, the Mayo Clinic's just, I mean, everything's so smooth, and I mean, we never had any issues. I mean, I mean, I guess this if you're gonna go to a medical facility, Mayo Clinic is definitely a place.
Yeah.
And I guess I will say from a standpoint maybe to get people to do it is definitely just communicate a little bit more because I think it really when we first injured it's just especially me I was so hard-headed I thought I was gonna walk out the hospital with a severed spinal cord so it's just kind of hard-headed and and I think there's nothing wrong with believing you can get better. You should. It's
Yeah.
just at some point you got to come to reality and make a decision. I think if the surgeons stay in contact with the patients, I know that's what made a difference for me. So yeah.
So just 2 quick slides in terms of what can we expect in terms of reconstruction. These were 2 recent studies from 2024. So looking at, these are patients who've had more tendon transfers, but on average, a pinch strength of 2 kilograms, a grip strength of 5 kilograms is what kind of, in looking at that entire group, of what patients were able to achieve. And this is another recent study with 14-year follow-up from a group, I believe, in Sweden, but they asked patients who'd had surgery in terms of their satisfaction if they would have surgery again, and 92% of patients stated that they did benefit from surgery in some way, and this was 15 years after they did have surgery. So wanted to say thank you again for the opportunity to be able to present here. Thank you to Jeff for your time, and he's very kindly offered for anyone on the call, myself as well, if you wanted to email us with any questions. I think we hope we should have a little bit more some time for questions now, but if anyone had any questions, please feel free to reach out. I'm happy to speak to them as Jeff is as well. So thank you again for everyone's time and for the chance to speak here today.
Well, thank you so much, Dr. Wu, for this excellent presentation. And Jeff, thank you for sharing your experiences as well. This has been a really interesting presentation. And wow, almost 90% of patients would report that they would do the surgery again. That's incredible. And I liked what you presented earlier on about kind of the distrust in hearing the information from surgeons, and it really underscores the importance of having, clinical staff who have built that trust and that relationship with those individuals to present the information. So really incredible. We do have time for questions, so please feel free to use the Q&A. I do see 2 questions already, so we can go ahead and launch into those while others are generating more questions. So Lynn Dorr asks, in doing the surgery to get pinch, would that pinch be as strong as what I get from my tenodesis splint?
It usually is stronger because that with your tenodesis, most patients, depending on where your finger lands, it just touches the side of the index finger. So most patients can pick up larger objects, but with the actual tendon transfer, one, that's pinch that you can use. If you kept your wrist stable, you could still move your thumb up and down. Your tenodesis, though, will only make that even stronger. And maybe Jeff can speak to that as well. But in general, I've heard from patients that the pinch is stronger than just what your tenodesis would give you alone.
Personally, it's significantly stronger. I mean, like I said before, I couldn't, I have like an iPhone 15 or whatever it is. I couldn't pick it up with my tenodesis. Now I can grab the phone, pinch it on the edge and pick it up. I can pick up pretty significant heavy things that I could not before. It makes a huge difference. Yeah.
Thank you. Lynn also has a follow-up. Does insurance cover these surgeries?
For the most part, they should. I haven't had patients have any issues, even those that are potentially out of network to Mayo for insurance coverage. So I haven't dealt with issues personally. This should be a procedure that is covered. Jeff, I'm not sure if you had to go through any additional steps being out of state in getting the surgery or the post-op covered.
No, it's covered.
Great. Kim DeChant asks, if someone had a failed nerve transfer, does that impact candidacy for a tendon transfer?
I think it would depend on the specific case. It depends on what nerve transfer that patient may have had. If someone has had a nerve transfer, I don't feel I would not use that same muscle to then use as a tendon transfer. So it does decrease some of the options. But I think on a case-by-case basis, there are potentially other things that we can do to help and use different donor muscles. But some common transfers, for example, if they've used your brachialis donor nerve to go into your finger for flexion, I wouldn't use the brachialis muscle or the brachyradialis muscle then if you've already had that nerve, because that muscle is essentially denervated. But there are potential options. It would just depend on the specific nerve transfer that you had, your specific level of injury, things like that.
Thank you. Other questions, feel free to type them into the Q&A now, or, oh, we have another one from Antonios. How long is a cast being used in tendon transfer?
So patients are in a splint, which is a half cast for 2 weeks after surgery. And that's 2 weeks, so not coming out of the splint 2 weeks full-time, day and night. After that 2 weeks, patients are then transitioned into a custom-made removable splint. And that splint you wear all of the time, except for when you're doing your hand therapy. And that's for, depending on the type of surgery and specific tendon transfers, for usually about 2 months. So you're able to remove it, you're able to do therapy, use your hand for small things, but you're in some sort of immobilization for about 2 to 3 months after surgery.
Yeah, I
Other
have it
questions?
on. I
Oh,
can show
sorry,
it.
Jeff.
I have it on.
Oh, yeah.
So, yeah.
Other questions for Dr. Wu and or Jeff? And if you need time to percolate on this a bit and formulate your questions, like Dr. Wu said, she's included their email addresses so that you can follow up later with your questions. So if you want to share your screen again, Dr. Wu, with the
Yes.
last slide, maybe.
Yeah. Sorry about that.
Great. And let's see. All right. Any other questions before I move on, or any final comments, Dr. Wu or Jeff?
I just want to say thank you again for the opportunity to be a part of this, and I'm open to any questions. If anyone is wondering about recovery, feel free to reach out either to Jeff and I. From my perspective, I've seen this really help to improve a patient's ability to do things for themselves in their day-to-day lives. But as Jeff said, I think there is understanding that post-operative recovery process is important, and knowing that Jeff's amazing result, a lot of that is his hard work with his therapist after surgery. So thank you.
Yeah, thank you.
Thank you both. And thank you all for attending today's grand rounds. Again, we apologize if you weren't able. Oh, look at that, just in time. Antonios, would you like, we'll answer this question as well. May spasticity complicate recovery? And thank you so much for a great presentation, he says.
Well, thank you. Yes, so patients with incomplete spinal cord injuries, spasticity can be more of an issue. And it can not complicate, but I think it adds a level of complexity. We would typically address your spasticity first. So sometimes that can be a different set of procedures first to help with your spasticity before we do some of the tendon transfer procedures that you've seen today. And when we split that up into 2 surgeries, sometimes spasticity is useful. For example, if the finger flexors are spastic, sometimes I use that to our advantage to give you a bit of a stronger grasp. And I've learned that every patient's spasticity is a little bit different. So it's kind of on a case-by-case basis. It does add another level of something else for us to consider, but it doesn't mean that patients wouldn't potentially benefit from surgery.
Great. And again, if you have other questions, please do reach out directly to Dr. Wu and Jeff. And so the recording for this webinar will be posted very soon on the SCIMS website with a link to our YouTube channel, so you can view it and see the slides there. And as a reminder, please see the chat for information on how to obtain CME credit for attending today's webinar. And then at the end of the webinar, a brief 3-question survey will pop up, and we would really appreciate your feedback. So thank you, everyone, and have a wonderful day.